Welcome to episode 253, Codependency Reconsidered, History, Stigma, and Clinical Alternatives, featuring Lara Okoloko, licensed independent clinical social worker. Make sure to subscribe to be alerted about future episodes by Clearly Clinical. Learn, grow, shine. Hello to our listeners. My name is Beth Irias, and today we are going to be talking about codependency. There's so much to be said on this topic, and I'm really looking forward to having Lara Okoloko here. She is a licensed independent clinical social worker, and this topic is important to her and something that she has spent a lot of time thinking about and working with. Thank you so much for joining us, Lara.
Yeah, thank you, Beth.
Before we dive into what is invariably a complex conversation, why don't you take a moment and tell our listeners a bit about yourself and about your background and how this idea of codependency has become something that's been really important to your work.
Yes. So I'm a clinical social worker. I'm in the Seattle area. And I have been working as a clinical social worker for about 20 years, but for 15 of those, my focus has been working with the family members of people with substance use disorders. And I now split my time about half and half between seeing clients myself and then teaching people. So I teach in an MSW program, and I also train clinicians in motivational interviewing and in a family approach called CRAFT.
Codependency. In the age of social media, that has got to be one of the terms that is used more than any other. Like, what a buzzword we have right there. And also potential misinformation about codependency. As we expand on this topic, Lara, will you first begin by telling us some of the history of the term codependency or codependent behavior? When did we start using it as a field? Why did we start using it, and kind of where are we moving now?
Yes. Okay. That is quite a story, I think. And I will start by saying that the term kind of showed up in the 70s, maybe, but was really not widely used then. And the term originally that was used was co-addict or co-alcoholic, and was really like a few articles hidden in the substance use disorder treatment world, but really not like a popular idea. And I think, can I tell you a story about it?
Absolutely. I would love to hear a story about it.
Great. So I think to understand where the term even came from when it was invented in the 70s, we have to go back a few decades. And I think the best place to start that story is with Lois W., who was the wife of Bill W. And for your readers who are not familiar with 12-step programs, Bill W. is one of the co-founders of Alcoholics Anonymous. And his wife, Lois, Lois and Bill met and fell in love in the 20s, even before Alcoholics Anonymous was invented. So they were together during the time when Bill had an active alcohol use problem. And their marriage was challenging. They had some infertility issues, infidelity issues, in addition to Bill's drinking issues. But they were a very committed couple. And Lois really dedicated herself really fully to Bill and Bill's well-being. And a big part of their marriage was her trying to keep him from drinking, keeping his drinking from causing problems in his business. She often was the wage earner for them as well, even after Bill was sober. And so when Bill did get sober, he did so famously by starting Alcoholics Anonymous. And so he said that he got sober, he credited, as he would say it, this room full of strangers, this group of men in Alcoholics Anonymous. And that was challenging for Lois. She really felt like she had dedicated herself to him and had done everything to help him. And then he gets sober and he's like, thanks to these group of strangers. And I think, that caused some resentment for Lois. And she described herself in her own words as feeling as addicted to Bill as Bill was to alcohol. And so you can see kind of the beginnings of the ideas of codependence in her describing herself that way. And then in their marriage and in his sobriety, it was normal at that time in Alcoholics Anonymous for mostly it was men in Alcoholics Anonymous, and the wives would accompany their husbands to a lot of their meetings. And so the wives would hang out in the parking lot or hang out in the kitchen and chit chat together. And that eventually caused some resentment for Lois too, is that even in sobriety, like his needs were kind of primary and was the focus of their free time. And so she writes in describing her own experience with it, that one night after dinner, Bill brought her shoes and for her to put on to say, all right, let's go to the meeting, Lois. And she kind of threw her shoe across the room at him and was like, damn you and your meetings. And it was kind of her resentment kind of boiling over. And from that, she ended up starting Al-Anon. And because she viewed herself as addicted to Bill, as he was addicted to alcohol, it made sense then to use the model of Alcoholics Anonymous to create Al-Anon, for her to engage in the same program of recovery in which the focus was on detachment from the drinking person in the same way that Bill detached from alcohol, and to apply the 12 steps to her own powerlessness over Bill, as Bill was powerless over alcohol. So you can see there's like this parallel that she applied. And so Al-Anon really has shaped our cultural paradigm, kind of our societal thoughts and beliefs about the family members of people with addiction. And it really was the only kind of model for thinking about that, which was really a model based on Lois's personal experience and her personal understanding of her problems. And which is interesting to me because for those that are familiar with 12-step programs, it's a program of tradition. It is not a program that gets updated all the time or that gets changed to keep up with the times. By definition, it largely stays the same. And so today, as clinicians, we have all these things that were either in their infancy at that time or had not been invented at that time. Things like family systems theory, feminist therapy, attachment theory. Like we have all of this development in the field that really doesn't touch this original thinking that Lois had, right? That kind of survives intact. So that thinking was there, that story was there. And then in the 70s, when this term kind of got coined, first kind of co-alcoholic into codependence, it really became popular more like the late 80s, early 90s, because of a few authors that probably a lot of your listeners have read books by. So Melanie Beattie with Codependent No More and Beyond Codependency, but some other authors too, Pia Mellody, Claudia Black, that were writing a lot about codependence and were writing books, some for clinicians, but some for a lay audience. And so that's where this like big jump happened, like over the wall from, things written for clinicians in this kind of niche corner of psychology to things that were just for the general public. And then kind of a second jump happened, which is what you started with, talking about social media and discussions about codependence, was the jump from being described only about people in relationship to someone with an addiction to a more broad description of the way people are in relationship with other people. And so, and the model I think that Lois proposed, which was, she didn't name the quote disease, which codependence is often named as a disease. She didn't come up with a name for the disease, but she did invent the cure. She was proposing that detachment and acceptance of lack of control and a focus on yourself was the cure. And so I think of it as this like kind of backwards development of, we had the cure and the idea, but we hadn't named the pathology or the disease yet until the term codependence got coined. And so then that kind of idea became complete. And I'm using the word disease, and you can't see I'm doing air quotes, but that it has been proposed as a disease, as pathology, as a mental health disorder. Although I think very importantly to recognize when we're clinicians and talking about this is that it's not in the DSM. There were attempts to put it in, I think in the DSM 3 to 4, there was some lobbying to have it included, but it wasn't included and it's not there, even though we talk about it as though it is a mental health disorder.
I really appreciate the story because I think it illustrates the complexity of loving someone who is engaging in a behavior or set of behaviors that are potentially confusing and unpredictable and scary, potentially violating. Like there's so much there. And I feel like codependency is one of those words that right now may have kind of gotten away from us, kind of like bipolar. Like I feel like 15, 20 years ago, it's like, oh, well, she's very bipolar. Like we use these words in this very colloquial way without real acknowledgement of what they actually mean and what concepts are being represented. And then when we've effectively over pathologized that word, it becomes another source of pain for someone who's potentially already been through quite a bit of pain to say, hey, you're doing it wrong.
I agree. I would go a little further to say that it didn't just get away from us. Like we never had a handle on it in the first place because we meaning clinicians, we don't have an agreed upon definition. And so usually, like what you're describing, there's first a real definition with actual criteria for bipolar disorder, for example. And then it kind of escapes from the world of clinicians into the general public and then gets used kind of any which way. Codependence never even was contained in definition.
What about dependent personality disorder? So as we kind of try to nail down what is this thing called codependency when we have not actually defined it, we being the DSM, which there are far more definitions of mental wellness than what we would find in the DSM, which is a separate conversation for another time. But working within the DSM as the reached for standard in American psychology and psychotherapy.
Like you're saying, what's the closest thing we have?
Yeah, like tell me about DPD and like where are we pulling some of these concepts from? Because we are using them clinically. It just may not be grounded in.
Yeah, I mean, maybe. I mean, let's can we think about even what like the words in there, dependent, but I don't even know if we would and all of us who use the word codependent would even agree that that's the predominant description of the behavior. And so we have these very, very different terms, depending on which author you read or, which, like Codependency Anonymous, for example, uses a totally different definition than Melanie Beattie uses. And I think part of the problem is not just the lack of agreement on definition. There's a second problem that I think is actually a bigger problem, which is that as mental health clinicians, part of our responsibility is to distinguish between typical behavior and atypical behavior. And because almost every single behavior in the DSM is a behavior sometimes experienced by everybody. And it's not all pathology. So part of our responsibility is to help people distinguish between sometimes experiencing an emotion versus having a disorder. The same way another one that is kind of misused generally in social media is OCD. And so that's another example of needing to distinguish between being a highly organized person versus having symptoms that disrupt your life and cause significant problems for you. And so if we look at, I'll give you Melanie Beattie's definition. So her definition is, a codependent person is one who has let another person's behavior affect him or her. That's criteria A. And who is obsessed with controlling that person's behavior. That's the second one. So the first thing I would ask is, Beth, do you ever let another person's behavior affect you?
Absolutely not. Never. No way.
You are a silo.
My kids' behavior never affects me. My neighbors, my partner, absolutely not.
Yep.
I am a rock. I am an island.
That's right. So this is immediately we have a problem, which is how are we distinguishing between pathology and being a human being in relationship to somebody? And then if we look at, here's Codependency Anonymous, here's their definition. They say, we offer no definition or diagnostic criteria for codependence. What we do offer from our experience are characteristic attitudes and behaviors that describe what our codependent histories have been like. We believe that recovery begins with honest self-diagnosis. We come to accept our inability to maintain healthy and nurturing relationships with ourselves and others. So that last sentence actually does they are defining it, although they're saying they're not, but that's the definition. That they're saying codependency is an inability to maintain healthy and nurturing relationships with ourselves and others. Really different than Melanie Beattie's description. And I think then this leads to another problem in distinguishing between typical behavior and atypical behavior is most things that people are using to self-diagnose are these long lists, pages of lists of description of behavior, which is much more akin to like a quiz in Cosmo magazine than actual diagnostic criteria and how we think about mental health. And so we have these things like one of them is, do you become resentful when others decline your help or reject your advice? Like, well, I think most of us are experienced with that feeling. Or another one is, do you put aside your own interests in order to do what others want? Which that one's interesting to me because to some degree, that is actually helpful behavior. For someone who never does that, we might think of them as having a personality disorder of a different kind. And so I think this is where, I certainly don't worship the DSM or think that it's perfect, but what it is doing is saying, let's agree on what something is, and then let's begin to help the clinician to be able to distinguish between what is just being a human being in relationship. And in this case, when we're talking about codependency, what we're usually saying is, what is a typical or expected behavior of somebody in a relationship that is under the strain of a substance use disorder? And so Melanie Beattie says that 98%, these are her words, that 98% of people in a relationship with someone with a substance use disorder is codependent. So then I would say, if something's nearly universal, it's not pathology.
Right. Where does dependent personality disorder fit into the mix? Because clinically, we're pulling it from too many sources. And I'm wondering, if we have this identified condition in the DSM that's saying, okay, here are these signs that now the proverbial we, have decreed are pathological, then in addition to the definition that's coming from 12-step, and then it's also coming from this really handful of people that have established themselves in the field in the last 20 or 30 years. And then are we also pulling it from dependent personality disorder and kind of cherry picking different concepts and being like, okay, well, this one is like this diagnostic criterion right here. This one indicates that you have dependency, quote unquote.
Okay. Yeah. I think about totally different. I mean, I understand what you're asking, and we can look at the criteria and see like how close do we think this gets.
Yeah.
But I think that what we're describing is more complicated than that. I think that when we're describing codependence, I think that we are sometimes describing a pattern of relationship to self and others that often started with family of origin experiences. And what I mean by that is I think some people have experiences of first relationships in which they are not allowed to be a boundaried self, that they learn for their own survival to read the room and to mind read other people and to attend to the emotional needs of their parents in order to keep themselves safe. And that they take those patterns into their adult relationships, in which there's upsides and downsides to that. These are people who might be very empathetic and maybe very attuned to others and maybe very deeply caring and giving and generous, but they may also have trouble maintaining a sense of who they are as a full self in relationship to other people. And that does not describe everybody who finds themselves in relationship with someone with a substance use disorder as an adult. But I think that is a common kind of precursor to finding yourself in certain patterns of relationship as an adult. But I think we have to add some other layers, which has to do with stigma, because a lot of the ways that we're describing codependence are about people in relationship with people with substance use disorders. And if we don't label and pathologize caregiving, even self-sacrificial caregiving, when we value the person receiving care. And so I think that's another element of why we devalue, why we might call it martyrdom. There's a lot of words like in codependency literature about like, being addicted to being a victim or being a martyr. It's like very negative, very judgmental language. And even the language around enabling, which is like very present in the codependent world too, is a negative view of being supportive of somebody else. So I think we have to add how stigma impacts this to say, how much does us not valuing the person receiving care influence the devaluing we have of the caregiving? And then I think there's a gender component, which is we expect this of women. And for people who were socialized as girls and then women, we expect that you are self-sacrificial in your caregiving to other people. And we do expect that part of your identity is based on relationship to others. And we do expect you to provide emotional labor at home and at work. So there's that element. And then I think there's a cultural element too, which is that psychology has been built on the value of the independent over the group. Independence is seen as more healthy than cohesion, and that the family value of the well-being of the individual over the collective well-being of the family is a cultural value, largely a white Western cultural value that's embedded in psychology. So to me, go understanding the layers of what kind of keeps the idea of codependency in place feels to me like a better way to understand, like, what is this? Why are we still using this type of language? Rather than finding like the closest thing that we have in the DSM, but to say we have to kind of pick all these things apart first before we could even get to that.
Absolutely. And I'm glad you bring up that point. In order to be able to effectively look at pathology, and even that's air quoted, we have to see through the lens that was making that determination. And I had the opportunity to take one of the personality profile tests a couple of years ago. Like I got my hands on it. I was like, I'm going to do this. And I was going through some of the questions and I was like, wow, that was a loaded question. Because like there was so much nuance that was completely missed in a, yes, this is true about me, or no, this is not true about me. And I'm like, well, contextually, like, like, hold on. And so you realize that we are attempting to boil down very complex relational concepts to something digestible, like this cute little soundbite, when it's actually much more complex than that. And I also appreciate what you're saying is like, we're so used to looking at this through the lens of substance use, but it can also exist outside of that.
Yes, it has. I think the way people use the term now is more like what you're suggesting around like personality disorder, is like it exists in you rather than it's something happening in the relationship, between two people.
Yes. And I think for me, conceptualizing this both as a professional and as a human being, what I have witnessed and what I have experienced, having been in relationship with people who have active substance use concerns, it's just littered with double binds. You are damned if you do, you are damned if you don't. And there is no easy solution and no obvious solution. And that situation kind of inherently sets you up.
Yes, you're right. There are a lot of double binds. And one of them that I was going to say is my favorite, but it's my least favorite, is the way that kind of societal wise, we tell people if they're in a relationship with someone in an active substance use disorder, that they are powerless and there's nothing they can do to help unless the person's ready for help. And at the same time, we judge people for enabling, which implies that they are influencing the person in a negative way. And so that double bind of you're totally powerless and any attempts to control is controlling, which is codependence. And at the same time, you are influencing them, but only in negative directions. That's terrible. That's a terrible way to talk to people who are trying very hard to stay connected in loving, supportive relationship to someone who is really struggling and sometimes behaving in ways that are really difficult to be in relationship with.
Yes. And also having worked in the highest levels of care for addiction treatment, sometimes really deadly consequences, terrifying consequences. And so the way that some of the language, I think, has been weaponized when you have a loved one who has no idea what to do because they're scared if they don't pick up the phone, if they don't give the person the money, if they don't give them a place to sleep on their couch or whatever it is, terrified of this consequence and the way that it can hold just the consequence really holding the control, and how scary that is for any of us to watch somebody that we care about.
Yes, but especially scary for parents. And this is where, a lot of my clients attend Al-Anon, and I certainly don't ever want to take away anything that's helpful to people. So this is not a condemnation of Al-Anon at all. But I do think it's important to remember that the whole concept of Al-Anon was started by a wife thinking about her relationship with her husband. It was not a parenting program. And so the idea that you can solve this by detaching from your spouse and focusing on your own self-care, I think that was a very empowering approach for Lois, especially you talked about contextual, especially in the context of the 1950s and gender relationship. It was, in some ways, like an empowered feminist way of dealing with the problem to say, I need to focus on myself. I deserve care for me. But is that the right approach for a parent terrified of losing their 20-year-old child to a fentanyl addiction, is to detach and take care of yourself? And if you don't, you're diseased?
I'm really glad that you bring up that difference because it's the lived reality of so many people. And we have so much capacity as mental health professionals to help and to hurt.
And our judgments are harmful to people. They're not just harmful because it hurts people's feelings. It's harmful because it increases shame, which increases social isolation. And I've heard from many people that their first attempts to get support from us professionals have led to them feeling judged and condemned and blamed. And then they don't want to reach out for help.
I'm glad you brought up blame. In the example you just gave, the difference between a spouse with addiction and a child with addiction. Goodness knows in our culture, we're pretty quick to blame if there are concerns with a child. And more specifically, we blame, if we're talking about hetero parents, we blame differently. Can you expand on that, please,
Yes.
Lara?
Well, mom blaming is an old hobby of psychology. And has been around for a long time. And so, this is another version of mom blaming, because it's often, if it's not women, it's behaviors we attribute to women that we are pathologizing here. And so I think exactly as you described, that double bind is, we are blaming people that the problem developed in the first place. We're blaming them for how they're interacting with the problem. We're blaming them for not fixing the problem, but we're blaming them for trying to fix the problem because that's enabling. It's all blame and very little supportive direction about how to actually be helpful. And in terms of development of in the field, we have methods for being helpful with these problems with families. There has been development in the last 20 or 30 years of family-focused models of helping families of adolescents and young adults and couples. We have alcohol behavioral couples therapy. We have brief strategic family therapy. We have craft. We have space for anxiety and OCD. We have all of these approaches for families, and they're evidence-based. But they are not as popular as these ideas that have been in the field for a long, long time.
One of the things that I have encountered in my work, particularly among people who are more apt to consume social media, so they're getting a lot of messaging about, take this survey and diagnose yourself. And the survey is not the Beck Depression Inventory. It's not validated. I'm being codependent, a client says. I have codependency issues and my partner and having that argument with their boss, and then I want to show up and blah, 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 and they're deconstructing it. What they are likely meaning is, I'm involved in this situation and I'm emotionally invested, and my emotional investment is bad and problematic. Is usually the way that I'm hearing that term used. From an attachment lens, if we're zooming out and we're looking at, beyond just the real-time double mind that might be existing in the moment right now, if we go back to some of the reasons why someone might have learned that this way of interacting relationally makes a lot of sense. Can you expand on that part where it's like, I would love to hear your perspective on presenting this information to clients that come in being like, I am so bad, I am codependent.
Yes. Well, the first thing that I always say when a new client describes themselves to me as codependent is I always first say, what do you mean by that? Tell me more about how you know you're codependent. Tell me what you're doing when you notice this is codependence. Because I really do get different answers from different people because it depends what they've read, what they saw, why they came to that term, what they're describing in themselves. And part of the problem with labeling is it removes our curiosity. Once we have a label for something, then we just say, oh, well, that's codependence. And we forget to be curious. Once someone starts describing what they mean when they say codependent, then I can continue that diagnostic assessment to figure out, are they talking about not having a self? Or are they talking about trying to control everyone around them because of their own anxiety? Or are they talking about their difficulty prioritizing their own needs because of something that's happening in this relationship when they do that? Are they talking about their intense fear of abandonment and their over-attunement to the other person, and they're willing to sacrifice themselves to keep connection? I mean, I first want to know what is the thing that they're describing, because then I can know what is the treatment then. What is the thing that they're wanting help with that I can help them to develop, whether it's, we talk a lot in this kind of arena around boundaries and helping people to have boundaries. And I think there's work that we need to do often before we even get to the part where we're coaching someone around, quote, having boundaries, which is one, an ability to read oneself. How do I know where my limits are? And because people tend to have trouble with that, especially those that get labeled as codependent, then we often are just giving advice or giving rules for them to follow, which is not an actual replacement for really having a self that has boundaries. And so even that ability to tune in, which my example earlier, maybe this was something they didn't learn as children, that they could, say, I don't like that, or that doesn't feel good to me, that they weren't allowed to have those kinds of limits, that maybe the work starts there. How do I know that this is beyond my limits? How do I know that I need to say no here? Right? Because if it's not helpful for me to say, you should do this or you should do that, you should kick them out, you should, because then they're just doing what Lara wants them to do, which doesn't really help them to figure out what they want to do. But that's just one example. Some people have perfectly easy time with boundaries, and the issue is something else. So I think there's one part, which is the diagnostic process of, if I wasn't using this label, how could I stay curious about what's happening here? And then there is the change strategies, which is what I'm really listening for when people are talking to me is, what's not working for you now? What about what you're describing isn't good for you, doesn't feel right for you, and maybe also is unhelpful to your loved one? And so how can we design some experiments in which we're going to, and this is systems thinking, how can we begin to see your family not as a collection of individuals acting on their own, but how can we begin to understand that your family is like a set of gears in which everyone turning is turning everybody else? And so we have some collective responsibility here for each person to identify their own part in these grinding gears and to change your own part, which is not blaming. It's not to say, let's figure out what you're doing wrong to cause these other things. Collective responsibility is not blame finding, but I think ultimately is empowering to people to realize, oh, I can actually change some things here, even if my loved one doesn't change yet. I can change my reaction, I can change my behavior. And in doing so, I change the system. And that's a different, that I think that to me is much more fruitful, much more helpful, and does not require that I tell people that something's wrong with them, that they have a disease, or to talk about them or their loved one in disparaging ways.
It sounds like for you, it's making sure you are expanding the nuance that that particular client is bringing in. Like you're not letting it be this simple thing, because again, social media is going to make it very simple, where it's like, if you struggle with this, then set better boundaries.
Yes.
And I've like seen the danger in that, because it's like, well, I tried to, and then this thing happened and I wasn't prepared for it. And now I've been cut off. And it's like, whoa, because it may lack the depth in appreciating, why am I doing the thing to begin with? What need am I actually trying to meet? How did it get met previously when I did this thing? And do I think it's going to work this time around, or what would I do differently? Which is a very different conversation. Like, it has a lot more complexity.
Yes. Well, it's the complexity. What you're describing is like a functional analysis. And it's the complexity of really understanding how all these behaviors are functioning in your family and in yourself, which again is not blame finding, but it's just figuring out we're all doing behavior that makes sense for something. And so can we be curious enough to wonder about that, which is both to wonder about your own behavior and to wonder about your loved one's behavior. So then we can see how their behavior and your behavior is intersecting to create patterns, and that those patterns are functional for something, even if you don't like it. And that is way more depth and nuance than certainly that social media uses, because I think the kind of zeitgeist of our era in psychology is the way that social media pathologizes being human. I mean, everything that in social media around mental health is, every quirk of personality is linked to some kind of diagnosis or disorder, and we lose the sense that human beings are just like quirky and funny and interesting and weird, and that then we're in all kinds of situations that are challenging and unusual and stressful, and we are all adapting. I mean, that's one of the kind of really fundamental things about being human, is that we adapt to all kinds of really challenging and weird situations. And in our adapting, we develop behavioral patterns in order to try to keep things balanced. And so if you come in out of context, you try to remove that from any context and just say, ooh, that's a weird thing that person's doing. There must be something wrong with them, while we ignore the function of that behavior that we're judging.
In my work, I have found myself saying things like, the dirty word codependency, and doing so in order to kind of highlight that this word, number one, may mean something different to you, client, than it means to me. And I almost guarantee that it does. But also, like you said earlier, like it carries so much negative association. When you are speaking with clients, what phrasing do you use to, I guess, knock the disparaging term codependency down a peg, or many pegs, so that we can actually talk about it, instead of, I think, what can happen, which is a shame spiral, where a client is self-flagellating, being like, I did the thing again. I'm codependent again. Why can't I stop doing this?
Well, I think to start, and I know it's so hard to give up terms that we've used as shorthand to describe stuff. So one is, I just don't use it at all. And so if clients use it, they'll hear me ask, tell me more about that. What do you mean by that? But they won't hear me mirror that language or use it. Often people will kind of drop that over time, or some people really like that term and they find it helpful to describe themselves that way, and that's fine. I won't take it away if they really want it. But because I'm not introducing it, I just find that it often just doesn't show up because I'm not using that label. And that process of kind of curiosity and also normalizing. And so we can normalize, by just saying, for example, a phrase I often use is just to say, behavior makes sense. And so from that perspective, inviting people, I love when someone says something like what you just described of like, why do I keep doing that thing? I love that question because one, it means you already have awareness, right? You have awareness that there's a pattern. You have awareness that you're doing a thing, but that you don't actually like doing the thing. Like we're already 50% there. So I think that's great. So I think one, just being affirming instead of saying like, that's codependence, that I would probably just be affirming of your awareness. And then I would be affirming that your behavior is probably makes sense for something. And then I would invite you to be curious about it with me, is to say, yeah, let's figure it out. I wonder why. You clearly don't like doing this behavior. It's not in alignment with your values. It seems to be coming at high cost for you. So it tells me that there is a hidden benefit to this behavior. Because if it didn't have a benefit, you wouldn't be willing to pay the cost. So do you want to look at it with me? And let's figure out, without any judgment, no moral judgment at all, why do you keep doing that thing? And then once we know why you're doing it, which there's often lots of good reasons why you're doing it, then we can figure out, is this a behavior you'd like to change? Which you get to decide. It's not up to me. You can keep doing it if you'd like to. And you can keep doing it knowing it comes at cost, but you also know what the benefit is. And so now you have some choice, but you might decide, I don't want to keep doing that behavior. And so then, great, let's think of some detours. The pattern's going to emerge again. The dance is going to happen, like from an EFT perspective, like the dance happens. You're going to be invited to dance, probably fairly soon by your loved one in this very predictable way. And now you get to decide, am I going to take a detour? And you and I can plan the detours together. So the detour might be a new skill you're going to practice, and then we practice it. So it's an experiment. So you go and you try the new thing, and then you come back and you tell me, did that make it better or worse for you? And if it made it better, we'll keep doing that. And if it made it worse, let's try a different experiment. But that is the process for me, which hopefully I'm doing in a way that communicates that I am warmly curious without judgment, that it's invitational, that you have autonomy, you get to decide, and that it's collaborative. We're going to look at it together. And I think the more that we are non-judgmental and non-shaming, the more we get invited into those places where people are doing things they're ashamed of. They can show it to us because hopefully they're trusting that I'm going to look at it warmly or neutrally and say like, oh yeah, that is interesting. Let's take a look together.
The phrasing that we're talking about here, when I'm looking back, at sessions and with individuals and couples and families and looking back in time, one of the things that I've come up against, and I'm really curious how you handle it, I guess not coming up against it, that has come up that I'm working with, is the use of these terms in certain groups that have been so clearly defined. So, and also knowing, so I'm thinking, coming at it from a 12-step perspective, every single meeting is different. So the way that a meeting is facilitated and the language that's used in that meeting is going to be different from the meeting on a Tuesday night versus on Wednesday morning. So there's that kind of individualization. One of the things that I've experienced working in addiction is the way that it's like this hard and fast. Well, that's the behavior. I need to label it. And then being like, well, let's talk more about that because I'm introducing then potentially a different way of seeing something than they have been conditioned by NA, for example. How do you approach that? Because I've had the experience with a client that has been in 12-step for 22 years. And it's like, this is the language that we use. And it's like, yes. And how do you introduce that kind of nuance and discrepancy there?
This is where, before even thinking about how, I just want to say, I think this is where we have responsibility as clinicians, is that self-help programs have slogans and other ways that they communicate. Even if each individual meeting is different, they create a culture. And that culture survives meeting to meeting to meeting all around the world. And in order to get that level of kind of cohesive culture, you can't have a lot of nuance. you have to have certain framing that is very simple. So there's a lot of slogans, there's a lot of quotes, there's a lot of passages that are shared and read in certain ways. There's even a story arc that everyone is trained. If you are familiar with being in a 12-step program, you're given a frame for how you tell your story, what it was like, what happened, and what it's like now. All of those things are structure so that you can pick up, you can just go to meetings and attend and listen to people talking. And by the time you have the courage to speak up, you already have been trained in how you're going to share, what you're going to share, what kind of words you're going to use. And so in order for that to be disseminated in that way without, just kind of by peers, people to people all over in different meetings, you just don't get to have that much nuance. And so as clinicians, and I've been thinking about this, especially in the world now of the future of AI and mental health care, if we want to be better than the bot that is going to soon be providing therapy to people, then we have to be able to have nuance. We have to be able to be curious. We have to be able to have multiple tools. We have theory. We have modalities that we're using that should be more. As clinicians, we should offer more than what someone can get from a magazine or a book or a free self-help meeting. Otherwise, why are people paying or a copay or private pay costs if they're not getting more from us than that? And so we have theories that help us understand how families function and understand. And I think we should be applying those things, which should then be more individualized and have more nuance than those things. And so I don't critique what clients are saying when they have those things. I don't take away anything that's been useful to them unless I see it harming them. And if I see that some of that lack of nuance is hindering them in their relationships or harming them, then I might start to ask some questions to invite reflection of like, is that always true? And is that true for other people or just for you? Is that a rule for others or just for yourself? Or, I might start asking those questions to help people expand their kind of tight rules for themselves that they have because of those types of slogans. And I think that's one of the ways we do it is we get curious with people about that. Like, is that pathologically controlling, or do you just feel that everything's out of control and you're trying to find some ways to bring predictability, for example?
It's a really interesting part specifically of addiction treatment. And also knowing that we're talking about this term of codependency beyond addiction. However, given really its origins, if we're looking at 12-step and this recognition of, there sometimes is this whole set of ways of being that may come alongside loving somebody who has a problem with alcohol. They're like, oh, you too? Me too. Okay, like we're noticing some patterns here. That in and of itself is its own culture. And so it's the culture of 12-step, the culture of Al-Anon, the culture of smart recovery. And I actually really appreciate that you just use the word slogans, because that's not a word that I've heard used in that way. And you're absolutely right that in the standardization, it, like many things, gets oversimplified. And as you're talking about it, what I'm seeing is kind of this really compacted concept that just kind of accordions up and opens up into all of these different layers, and being able to do that in a really culturally thoughtful and humble way. Because that's one of the struggles that I've seen is like, well, this world that I've been in says it this way, and this is how I've been conditioned, and these are the words I use. And then for me, wanting to be really thoughtful of like, how do I respect that language and honor what it's giving to you, what it's given to you, and how it makes sense to you, while also being able to appreciate kind of some of the nuance here, because some of these programs in their standardization or the way that they're led in different groups can produce more shame.
Yes. And it just requires, in order to tell, this is what I think about narrative therapy would say, in order to be able to tell a really simple story, we do have to shave off a lot. We have to leave a lot out. And if we think from a narrative therapy perspective, what we are trying to do with people who have kind of dominant discourse in their stories of themselves is to help people complicate their own stories. So we're not saying your story's wrong. We're saying, yeah, those are some true things that you're saying. So people, when they're talking about codependence, are often describing common patterns. That's useful to be able to recognize common patterns. But that we're saying, okay, those are some true things in your story, but also, is this other thing true? And what about this other thing? And where did you learn that? And what would it be like to think about it this way? So I think that complication of the story is what I'm going for, rather than taking away something that maybe is useful to somebody.
In the way that you are presenting and conceptualizing codependent behavior, quote unquote, and wanting to make space to appreciate the importance of context so that we're not oversimplifying it. It sounds like the real benefit that we're offering to clients then is the ability to break down 30 different variables instead of just one of like, I always do the thing, but to build insight and then be able to make the jump from insight to change. And I think that's been one of the things that I've struggled with and I've worked with clients for, where it's like, well, I know I'm doing the thing and I could see it happening and I understand it, but I do it anyway. And so it's like that jump. And then for you, it sounds like you're really just trying to empower the client's autonomy.
Yes. If I feel like there's a few core things that no matter what modalities we use, no matter what kind of work we're doing, there's like a few things that to me feel like good therapy or a good outcome from therapy. And one of those to me is if our clients leave therapy feeling that they're more at choice in their lives than they were before, then I feel like we've done a good job. So people can choose the old behavior, but now they have new behaviors they can choose, that they don't have to just do things one way because it's the new way. I think that's the thing I'm hoping for, is that people have increased awareness of themselves and their loved ones and the patterns between them. And in the awareness, they feel more empowered to make choices in how they interact.
Given your background, the models of psychotherapy that you've mentioned today and kind of how you're organizing information, for a clinician who's listening to this going, wow, there's a lot here. Like there's kind of what I've been told by whatever source about what codependency is, and this automatic negative thought that's saying like, that's bad, and wanting to make space for that complexity. How do clinicians begin to learn to do that? Like what do you find are the best resources, I guess, to really start questioning?
I would say the first thing, which is the one that I train people in, not necessarily because I think it's the only way or the best way, but I think it's an entrance in that is really accessible, is that I train people in CRAFT, community reinforcement and family training. And I think it's the best entrance into an invitation to think about things in a different way. And the spirit of CRAFT is quite different than detachment-based approaches or confrontational approaches like doing an intervention. And it's a concrete set of skills that help with what we're talking about, which is what can people do instead? So I know that I do this thing. It's not good that I do this thing. It's unhelpful that I do this thing. Okay, so here's an alternative thing to do. And I believe, kind of as someone who, CBT is part of my orientation, that people don't unlearn behavior. We can learn new behaviors, but our brain doesn't forget the old behavior. And so that's why it's not enough for us to just have the awareness, because now we're aware, but we keep doing the thing because we don't have a new behavior. So I think having concrete skills that are usually useful to most people in those situations, and it's fairly easy to learn, I think that's a good entrance. I don't think it's the whole thing. I mean, to me, I use CRAFT every day with my clients. I use it as kind of an organizing principle that's kind of easy to tell people about and invite them into. But the way that I deepen that skills-based work is with a lot of other models that I have found really helpful. So I use, I think, systems thinking, no matter what modality you choose to use, but any of the strategic, systemic type family therapies, I think you can choose any of them and get a deeper understanding of the way that people are interacting with one another to co-create patterns. So I think like pick any one so that you can deepen that understanding away from the way that psychology has always taught us to only see people as individuals, and then have something that is skills based, like craft. There are some other similar ones. I mentioned alcohol behavioral couples therapy, and space for anxiety and OCD. So any of those skill based ones that fit your client, like the kind of clients you see. And then I have found motivational interviewing really helpful for me to understand the way that often ambivalence is a really helpful frame to understand why people are saying one thing and doing another thing, or saying they want to do one thing but doing another thing, and a way to really like radically respect self-determination and autonomy in the work that we do with people. So I think, we can all go in different directions of kind of what do we bring together to create the depth that we want in the work that we're doing. But I think that to me, the easiest entrance is craft, because it was specifically developed as an alternative to Al-Anon and interventions, and kind of gives a frame for that work. And when I found it, it felt very intuitive to me. And it felt really useful to have this like concrete evidence-based practice as a reason why I was working in this way, instead of kind of feeling like I was both winging it and also not doing kind of the standard. And I think anytime we're doing something alternative or different than the standard, we need to be not doing it alone.
I really appreciate what you said there about the systems piece, given that I'd have to think about this more, but I don't think any of us can be quote unquote codependent by ourselves. It's inherently relational, and that means we're always bouncing off other things to inform what we're doing. And I think that's really helpful because of the oversimplification. When we're like, you are codependent, what you're doing is codependent, without, again, zooming out and seeing this relational context. So I appreciate not only the mention of things like MI and craft, but also like, let's look at it through a systems lens. And the EFT mention, like, shout out right there of like, everything makes sense in context. For any of us, human and clinician, to like, I guess, take a beat and step back and appreciate the value of what's happening here in the pattern that's unfolding. There's a much bigger concept here, obviously, beyond just let's redefine codependency. In fact, let's really tear it down to begin with. Like, forget redefining it. Are there any particular resources in addition to what you just said, which is like what you were just talking about was really let's look at the spirit of what we're doing with clients, looking at the foundation and our belief system around autonomy and cultural humility and the way that systems are acting. And then there's like this kind of slogan-y simplification. Are there any resources that you find are really helpful to help us kind of deconstruct and challenge some of these buzzwords that have become so big in our culture?
I think I'm realizing that we've gotten this far into the conversation and I haven't said anything about harm reduction and the way that has shaped the field. And so I think I will definitely be upset with myself if I don't kind of bring that piece in, and that there is a community of providers and a development of thought that has been going on for decades, that I think everything we're talking about is like the family part of that really similar work of challenging some of these ideas. And then, which is the beginning, is like we challenge the idea and then we begin to develop new ideas. And so if we think back to like the development of motivational interviewing, the basis for that, as I think Bill Miller would describe it, is realizing that the thing that we were describing as being a personality flaw of the person with addiction, their resistance and their denial, and there was actually an interpersonal phenomena that was being turned up by the clinician, being confrontive and judgmental. And so I think similarly, stepping back to look at how do we challenge these ideas? How do we then bring them into a modern era? And so I think we can ground ourselves in a number of different philosophies. I've also found feminist therapy to be really helpful for me to understand power and power dynamics between people, between me and the client. So I think there's a lot of ways to help ourselves in the development of the way that we think about these things. And probably, I've been influenced by so many different people and so many different authors and clinicians and researchers. But probably my North Star in all of my work is a quote by Alan Marlatt, who wrote books about harm reduction, and he was here at University of Washington, which is where I live. And he described harm reduction as compassionate pragmatism over moralistic idealism. And that is I feel like, regardless of which modality I'm using in the moment, regardless of kind of the mix of approaches that I'm using, if I need to kind of reorient to what I'm doing and to what my values are in my work, it is compassionate pragmatism. Am I being respectful of the person in the room and their family member? Am I treating everyone with dignity and a right to autonomy? Am I just figuring out what works and doing more of it? Even not to be too rigidly attached to my own modalities, but instead to just being pragmatic. Because ultimately, all I want is to be useful and effective to the families that I'm working with, not for them to mold themselves to my ideas or ideals. And so that moralistic idealism can look like a lot of different things, but it can even look like rigidity to our own models and ideas.
Absolutely. And I really appreciate you sharing that and bringing harm reduction into this conversation.
Yes, because that's the thing, that if we can move past codependence as an idea, which really stops people from being connected and supportive to their loved ones, even in ways that are helpful and healthy, is that we are moving towards a more harm reduction oriented way of working with families, and away from some of the morality, puritanism, kind of condemnation, cutoff way of doing that. And so we can make it, when people ask me things like, should I kick them out? Should I pay their rent? Should I, drive them to this thing? I can just say, I don't know. You're not going to get my judgment either way, but let's talk about it. Let's figure out how you would know if that's okay with you or not okay with you, or if that's helpful or not helpful. And so we can just kind of clear the air first, and not have it be from these like rigid ideas that are very judgmental, to say, let's figure out if it's better or worse for you and for them. What have you tried? How did that go? What's your value here? What's your main goal here? And I just think there's a way that we can kind of clear the air and clear the field, and then be able to be curious and be open, and see things more clearly, see our clients more clearly, see their problems more clearly, and really respect that people are doing the best they can, and they sometimes can see things we can't see, and that we can really collaborate together to figure it out.
Fantastic. Lara, I feel like there is so much more here to say than what you've shared in the last hour. For our listeners that want to learn more about you and about your work, what's the best way to do that?
Well, I would say first, beyond me, one of the best resources I think for this work with families is a website called Helping Families Help. And it has a provider side of that website and then a client side of that website that can help people find ways of supporting people who have a loved one with a substance use disorder. And you'll see me on that website. And I also have my own website, which is caresnw.com. And on my website, I have some resources for both clinicians and for families, and links when I am providing trainings. Then I put them up on my website.
Fantastic. Again, for our listeners, we have had the pleasure today from hearing from Lara Okoloko, licensed independent clinical social worker. Lara, thank you so much for joining us. I think you've given us and given me a lot to think about, and I really appreciate you coming on and shedding some light on the topic and adding some complexity to something that can be damaging in the way that it's oversimplified.
Yeah, thank you, Beth. This was great.
You've just finished listening to another exclusive continuing ed podcast by Clearly Clinical. If you like what you just heard and you need continuing ed credits, please visit us at clearlyclinical.com to check out our one-year membership, where you'll have access to our growing library of continuing ed podcast courses. Clearly Clinical, where our goal is to help you learn, grow, and shine.